Okay, so this lecture is going to be on opiates and antihistamines. Let's go ahead and get started here. Opiates, one of the more controversial medications that you'll be giving, but one of the most effective pain-relieving medications that you'll be giving as well. All right, so when do we use them? We use them as analgesics. That's one of the most common. Remember, the term analgesic basically means pain reliever. There can be opioid and non-opioid analgesics. Examples of non-opioid analgesics: ibuprofen, naproxen, Tylenol, aspirin, so on and so forth. We're going to talk about how opioid analgesics work, but they typically work by stimulating the opioid receptors. So when we talk about tolerance, cross-tolerance, and addiction, remember, what is tolerance? That's when increased dosages are required to produce the same therapeutic effect. So patients who are on chronic long-term opioids will typically require higher and higher dosages. These patients, because of their risk for addiction and dependence, are very closely monitored by a physician, and those dosages are monitored and adjusted very deliberately. Also, cross-tolerance, if you'll remember, that's a tolerance to a medication that is in the same class. So an example that I'll give later, but let's say I'm on morphine, and I've been using morphine post-procedure for 2 weeks, and I've developed a tolerance to that. And now all of a sudden I switch to fentanyl or Dilaudid. It's in the same class. It affects the same receptors. It's going to create the need for a higher dose of that different medication, even though I haven't developed a tolerance specifically to that medication. It's in the same class, cross-tolerance. Some of the risks of using opiate analgesics typically have to do with sedation, respiratory depression, and worst case scenario, apnea. Patients on overdosed opioids don't die from a cardiac dysrhythmia. They die due to respiratory arrest, apnea, which causes the cardiac dysrhythmia. So let's talk about your opiate receptors, your opioid receptors. They're located in the central nervous system, as well as the peripheral nervous system and the digestive tract. One of the things that you'll see with patients who are especially long-term opioid users and patients, they deal with constipation issues constantly. These patients typically use laxative, fiber supplements. You might get called for somebody who hasn't had a bowel movement in 4, 5, 6 days. And the pertinent question is, what kind of medications are you on? Typically, you'll see that they are on opioids. So what happens when you activate these naturally occurring opioid receptors? Well, it alters the perception of pain and causes feelings of euphoria. The alteration of the perception of pain is the therapeutic effect for it. The feeling of euphoria, as you'll see right there, that is the effect that patients or people who use this class of drugs recreationally or develop a dependence. They develop a dependence due to that feeling of euphoria, as well as a physical dependence as well. There is a huge social stigma right now. As a reminder, dependence issues and drug addiction, that is a medical problem. It's not a choice with the patient. While there is a certain aspect of choice when it comes to dependence and addiction treatment, there is a physical and mental dependence on these medications that's not going to be fixed by our little chat in the back of the ambulance when we have these patients for 15 minutes. This is a larger issue than what we have. That doesn't mean that you're not blunt and honest and professional and kind with these patients. It's definitely appropriate to say, sir or ma'am, you were this close to death, and you weren't breathing. If we didn't reach you in a few minutes, you probably would be dead, and there was nothing we could do. That's an appropriate conversation. It's a realistic conversation for a patient, and it's being upfront and honest with them. We're not going to be coaching these patients as far as addiction treatment. We're not educated in that. We're not trained in that, and also treating them in a non-judgmental manner is important as well. All right, so I've got a couple of videos that we're going to watch. The first one is some facts on the opioid crisis in America right now.
The opioid epidemic. It's the deadliest drug crisis in American history, killing about 90 Americans every day, roughly the same number as car crashes. Here are short answers to some key questions about the crisis. What exactly is an opioid? Opioids are a class of drugs that interact with opioid receptors on nerve cells in the body and brain. They regulate pain and affect the brain's reward or pleasure system, which can make people feel high. That makes opioids powerful painkillers, but also extremely addictive. So what is the crisis about? The current crisis started in the 1990s, with the overprescription of opioid painkillers like OxyContin. Over the next decade, a growing number of people became dependent on these drugs. And for many, what started with pills grew into a heroin addiction. Then in 2014, potent synthetic opioids like fentanyl began entering the drug supply in large amounts. Where's the crisis most severe? It's worse in the Midwest, Appalachia, and New England, but it really is a national problem. Synthetic opioids are continuing to enter new markets, especially in the Northeast and South. Why has it gotten so much worse in recent years? Decades of opioid overprescription, an influx of cheap heroin, and the emergence of fentanyl, a synthetic opioid that is 50 times more potent than heroin. Shouldn't we just stop prescribing opioids? Not necessarily. Opioids have improved the quality of life for millions of people, particularly cancer patients and those with acute pain. And suddenly removing access to opioids from those who are dependent on them to function could easily push people to more dangerous opioids, like heroin or counterfeit pills. So what can be done? There are many variables, but any solution would require controlling the distribution of prescription opioids, expanding access to medication-assisted treatment, and making naloxone, an overdose antidote, more accessible. In addition, more controversial ideas like drug checking services or supervised injection sites may be necessary to slow the rise in overdose deaths.
So, as you'll see, and as I've talked about before, the opiate crisis is not just street-level heroin. Prescription drug abuse and prescription painkillers are actually one of the most common overdose victims that you're going to be treating as a paramedic, and also dealing with on dependence issues and long-term care. The next video I'm going to show you, this is a typical overdose response from first responders. Police will get there, then EMS will get there. The patient is pretty much apneic, pretty close to death when the law enforcement arrives, and you'll see how the progression takes place.
Let me pull him out. Sure. Get him on the ground. Get him on the ground. Sir.
So one thing I'd like to point out, deep painful stimulation with this patient will not work. This patient is, as you remember, one of the beneficial therapeutic effects of an opiate is an altered perception to pain. This patient is so dosed right now, he will not feel that pain. So these law enforcement officers, rightly so, do not provide deep painful stimulation.
What's his medical history?
I don't know. You just picked him up 10 minutes ago.
You just picked him up?
Yeah, he's like, I need some money, can you put me to work? And I said, yeah.
He's got a pulse, he's breathing, so.
Hey, grab gloves.
He's not breathing. I don't know, drug related. Give me a flashlight, I can't see his eyes.
So as you'll see right there, this officer now decides to provide that deep, painful stimulation. Obviously, no effect. This patient is showing signs of apnea, respiratory arrest, respiratory depression. As EMS providers, what we would do when we get there, first things first, suction the airway, make sure that airway is clear, and then we would provide positive pressure ventilations if necessary. Narcan really becomes secondary at that point because you need to breathe for this patient first. And even before that, make sure that there's nothing in that patient's airway that he's going to aspirate.
Go left nostril. 5-6 Narcan deployed in the left nostril.
He's mine?
Excuse me?
He's mine?
No, just the one.
One.
14, 15. Let's see, they might get here before
We're
you.
doing together. The record.
Go ahead, put it on. There you go. There we go, hold on. Alright, take it off.
So as you'll see there, the patient is now woken up, that Narcan's taken effect. Law enforcement looked like they had a bag valve mask, but they weren't providing positive pressure. They may have just been giving supplemental O2 through that. But they're typically a pretty typical overdose scene. One of the things that you need to think about when you're giving opiates as an analgesic is the potential for an overdose. Now, you're typically, unless you really mess up as drawing up your medications and you screw up the concentration, you're pretty much not going to create a overdose situation such as that. What you could do, though, is create some increased respiratory depression, not to the point of apnea, but maybe not adequate for the patient. Also, remember, it causes the patient to become sleepy, and you might have some airway protection issues. So you kind of get into that range where your patient is resting comfortably, but they're still alert enough where they can speak to you. It's kind of the target range. The opioid medications that you're typically going to be giving, morphine sulfate. This is a longer acting medication. It's much cheaper than fentanyl, but it does come with some other side effects. As you'll see right there, it's known to cause nausea or vomiting up to 60% of your patients. Highlighted and bolded, obviously for a reason. You do need to know that. May produce a histamine release, so some patients are allergic, anaphylactic reactions to morphine sulfate. A lot of patients will say, hey, I've got an allergy to morphine. It's important to ask, especially if morphine is indicated, what is your allergy, what actually happens. A lot of patients will say nausea and vomiting. Well, we can treat that. Let's prophylactically treat that with ondansetron, Zofran, in order to prevent that nausea and vomiting. Fentanyl, extremely potent, extremely effective opioid analgesic, does not cause the nausea or the histamine release in the same incidence as morphine. One of the big benefits is it can be administered intranasally. It can be atomized, so it works great for people that you're having trouble getting IV access on, pediatrics for sure. Opioid antagonist, this is review for everybody, but remember within that opiate receptor, it basically kicks the the opioid out, and it wants to occupy this receptor. And over here, you might have your opiates trying to get into that receptor, but it can't because Narcan has a greater affinity, right? Has a greater attraction. It's a stronger magnet for that opioid receptor. Administer enough to correct life-threatening conditions. This is a big one too. Narcan is given to reverse overdoses, not doses. Just because your patient is high on an opioid doesn't make it appropriate to administer naloxone. Naloxone is to regain a spontaneous respiratory rate and protection of an airway, not to take somebody's high away. All right, as a review, histamine. That is a chemical that's released from mast cells in the event of an allergic reaction. Histamine can be released locally or systemically. What we're really concerned about when we talk about anaphylaxis is systemic release. Activation of the histamine receptors, all right? What does that cause? Inflammation, because it causes increased blood flow, increased permeability to the vessel walls, and that's when you get that third spacing and edema. It may cause GI upset, respiratory involvement. That's really dependent on the allergen. There's 4 histamine receptors, and we are really only concerned with these when we talk about antihistamines. As you'll see, H1 receptors, that is the main one that we deal with on a systemic anaphylaxis, right? Because anaphylaxis is defined as a systemic allergic reaction. You have the bronchoconstriction, you have vasodilation, smooth muscle relaxation, and vessel permeability. H2 receptors are in the stomach lining that can cause nausea and vomiting, gastric acid release, and so stimulation of those H2 receptors causes increased gastric acid release, causes the nausea and vomiting. H2 antagonists are indicated in ingested allergens as well as any gastric involvement as well. So the first antihistamine that we talk about, diphenhydramine, that is also called Benadryl. This is very common, and its treatment of allergic reactions. It will cause some sedative properties, and it does prevent coughing a little bit. That's not why we give it. We prevent the activation of those histamine receptors, which stops the vasodilation, stops the smooth muscle relaxation, and prevents the hives, prevents the third spacing, prevents all of that edema. We typically give it IV or IM, and some adverse effects, mild sedation, palpitations, anxiety. Anytime that you are considering giving epinephrine for an allergic reaction, you absolutely should be giving diphenhydramine unless it's contraindicated. Your H2 antagonist, most common, famotidine, which is also Pepcid. That targets your H2 receptors within your GI tract, and that will also stop the increased gastric acid production, and the nausea and vomiting as well. So, if you have any questions, make sure you write them down and submit them via the assignment, and we'll see you at the lecture.